All right, all right, all right, all right. Let's get it going, Khashayar.
Okay, let's start. So I took inspiration from Kirtan with him naming his cases, and this case is called Another Break in the Wall. And the first aliquot is that our patient is a 72-year-old woman who presented to the ED with the retrosternal chest pain. And I'm gonna stop there before giving you any information.
Awesome. First of all, anything you do to copy Kirtan is a good thing. But I will tell you, once you give the title, I'm going to be incorporating that into my analysis of the case. Um, but jokes aside, I think chest pain is one of the most common symptoms that patients present to the emergency department with. And actually, chest pain is something that a family member may call you and say, "Hey, I'm having chest pain. What should I do?" And I think when you're dealing with chest pain, the tempo and the quality of pain are very important. Here, we don't have the tempo, meaning the time course yet. We'll get that shortly, but we have somewhat of the quality that it's retrosternal. I know many of you are familiar with the 422 for do not miss causes of chest pain, but I really think of just three causes I can't miss up front. Like when I'm going to see that person in the emergency department, I tell myself acute coronary syndrome, aortic dissection, and pulmonary embolism. Those are the three causes. And what's really cool about time course and tempo is if a patient can recall the exact time that they started having the chest pain, it really increases the post-test probability for a dissection. But you don't, even though you think of all these causes, you don't have to rule each one out with very expensive testing. But all patients that come into the ED with chest pain, at minimum, deserve an EKG, a troponin, and a chest x-ray. All comers. So I think we're going to need much more information to go beyond the three life-threatening causes. But really, those are the things I'm thinking about. And I'm going to be very interested in learning more about the time course, associated symptoms, and her past medical history, which might affect the post-test probability for each of those causes.
Amazing. So, uh, the pain radiates to her back and left arm. Started this morning, and she had been experiencing it the entire day intermittently. She couldn't move around and do her daily activity because the pain started getting worse as she moved around. Her initial EKG in the ED didn't show any changes in the ST segment, and this is her initial presentation. She had similar experiences of pain during activity before, maybe 3 to 4 times a month, but they were never this intense. And we know that her son had died 2 nights ago. She also mentions a history of dysuria for the past week, but no history of urgency or frequency. For her medical history, she had diabetes since 15 years ago. She had a CABG 10 years ago. She had CKD, probably due to her diabetes, since 10 years ago. And she had diabetic retinopathy, for which she underwent surgery 12 years ago. She knows medication has been prescribed to her for her several conditions, but she doesn't take any of them except her insulin and aspirin. And she doesn't know the name of any of them either, and she doesn't have them with her either. For her social and habitual history, she doesn't smoke cigarettes, but she occasionally smokes hookahs and has a history of baking bread in traditional furnaces when she was younger. She doesn't drink alcohol and doesn't use any drugs. She lives alone, and her three sons check on her occasionally. I'm going to put all of this in the chat as well. So, yeah, that's the second aliquot.
Man, I'm so impressed by how well you speak English, Khashayar. I would think you're here in the US, you're my neighbor. Um, the the hookah is an interesting thing. I grew up in Iran, or I spent 3 years in Iran from 11 to 14, and I remember going to the mountains. What is it called? Darbak? What's
Darband?
Darban? Merci.
Darband Darake.
Darban Darake. Thank you so much. And I remember as like a 11, 12-year-old kid, I would see young teenagers smoking this hookah and blowing the thickest smoke in the air. And it reminded me a lot of like Snoop Dogg. And I remember I asked my uncle, hey, can I do that too? And he's like, of course, why not? And so I picked up hookah in Iran. And then later, after learning that, like, I think one session of a hookah is equivalent to like a pack of cigarettes, I put it aside and I do it occasionally, for celebration to take me back to the motherland, that being Tehran. But I think we get a lot more interesting data here. This poor lady has lost her son 2 days ago. And I don't think it's very difficult to imagine anyone coping with the loss of their kid. That's such severe stress. What that does for me is it does two things for me. One, it makes me think that she's under a lot of stress. Her sympathetic nervous system is activated. Her catecholamines are surging through her body. And then two, we know that there's this condition of stress-induced cardiomyopathy that can really mimic a ST segment elevated MI. And I wouldn't lead with that as the most likely diagnosis here, but it's something that's in the back of my mind, and I would include on my DDX. The other thing we learned is that this is a patient who has coronary artery disease to the extent that she got a cabbage, and she has other major risk factors for coronary artery disease, including diabetes, hypertension. And if you ask the question, what do patients with end-stage renal disease die from? It's usually related to the heart. So she's very high pretest probability for coronary artery disease, return of coronary artery disease. In these cases, if I were a cardiologist, the prior coronary angiogram would be really helpful to see what the vessels were like, what their disease state was like. But all of a sudden, we went from 72-year-old with chest pain to 72-year-old with history of cabbage, many coronary artery disease risk factors, who's coming in with chest pain. So now when I'm thinking of those three causes, ACS, dissection, and PE, I really have to rule out acute coronary syndrome. And I'm so glad she took her aspirin. The one thing you can do as a bystander when you're out in public or someone has sudden onset chest pain is give them aspirin. Like, aspirin is a class 1 recommendation in the context of ACS and plaque rupture. But then we talked about the quality of the pain. And what Khashayar told us was that this patient is having pain that's radiating to their arm. The pain radiating to the arm can be good for ACS. It can be good for dissection. But he also said that pain is radiating to the back. What that does for me is all of a sudden says, hey, Rez, maybe we're dealing with retrosternal pathology. And now I really have to think about aortic dissection. It's not true that in all comers, I get a CTA to evaluate for dissection. But if someone gives me this description, even if their troponin is elevated, I'm going towards that CTA. Now, interestingly, based on what diagnosis you're investigating, whether it's dissection or PE, the radiologist will time the picture taking after contrast differently. That being said, you'll still, when you're looking for an aortic dissection, you'll still be able to see if there's any major pulmonary embolus in the segmental vessels. We know this patient doesn't have a STEMI. We've ruled that out, as the patient doesn't have any SC segment changes, but they can still have acute coronary syndrome if they have an elevated troponin. Then Khashayar told us one more interesting fact, that she's had these symptoms, but not this intense before, months before. And so then what does that do for the post-test probability of an aortic dissection? I don't think it's enough to rule it out by any means. You know, every disease in medicine can exist on a spectrum. It can be smoldering and then finally come to clinical attention. And it wouldn't be surprising to me if someone has hypertension, isn't taking any medications, has risk factors for atherosclerosis, and then has a stressful event that just overwhelms their cardiovascular system. So I think what this aliquot does for me is one, reminds me of Iran when I was a young kid and I would smoke hookah trying to emulate Snoop Dogg. But it also tells me this patient has so many risk factors for coronary artery disease. This patient is having a type of chest pain that's very worrisome for dissection. And this patient just had the most stressful event that I think one of the most stressful events that any human can go through, which is loss of a kid. So I'm very nervous, Khashayar. I'm already getting the troponin. I'm going towards the coronary. I'm going towards the CTA evaluating for dissection and PE, and I don't care what her creatinine is. It doesn't matter at all to me because this patient needs that type of testing. But we'll get the exam. You know, we'll do the blood pressure testing in both arms, but even if it's normal, it doesn't dissuade me. Why? Because only 10 to 15% of patients with dissections will have different pressures in both arms. Only 10 to 15, even though in med school you're taught, oh, dissection, asymmetric blood pressure. It's not very common in that condition. And yeah, so I'm looking forward to learning more from you, Khashayar John.
Amazing discussion. Love all of the info. I'm gonna in this third aliquot, I'm gonna give first an initial physical exam and vitals we got from the patient. But I'm gonna say one more thing, that the patient was relatively stable during her first day of stay with us. Like, we approached in a similar manner, but during her first 24 hours, she was relatively stable. She was afebrile with a heart rate of 80, initial blood pressure of 160 over 110, which remained stable, and it was equal in both arms. No difference manifested itself. Her respiratory rate was 15, and on her first day of hospitalization, she was sitting on room air at 94%. She was generally looking ill, but she was non-toxic. She was oriented ×3. Her cardiovascular exam showed an S3 on heart sounds, but no murmurs. Pulses on all extremities were normal and symmetric. Her pulmonary exam didn't show much of anything really, like I couldn't hear much on her exam, but she complained of dyspnea since the pain had started. And she told me that she sleeps with 3 pillows under her head at home, but she didn't mention any history of orthopnea or PND. On her extremities and skin exam, she had bilateral lower extremity edema, left leg more than right leg, but the size difference was not significant. That like points us to an immediate DVT, yet it existed. The rest of her examination was normal, including the abdominal exam. We didn't hear any thrill or bruit on her abdominal exam. On her second day of examination, she developed a fever with coughs and dyspnea, and she was saturating at 70% on room air, and later with 4 liters of oxygen, she was sitting at 97%. And right now, I want to show you guys her EKG on the second day. If I can share. I don't think I'm co-host.
Sorry about that, Khashayar. I just made you co-host. Man, you have us so intrigued from chest pain to the back to all of a sudden fevers and edema. Wow.
Can you guys see my screen?
We can. It's saying TB. It's like a TB diagnosis.
Yeah. This is the EKG. This is her EKG.
This is her EKG. Okay.
And yeah, I'll
What
leave
I'd
you
like
guys to
everyone
it.
to, yeah, that's great. What I'd like everyone to do is just take 30 seconds. Look at this electrocardiogram. Think your Khashayar on hospital day 2 and interpret it for yourself. And then in 30 seconds, I'll take a crack at it. I had learned that Robbie was in the waiting room and he texted me. He's like, man, why aren't you letting people in to the VMR? I wish that he was available so I can tell him to discuss this EKG. It would take 30 seconds and I'll take a look at it myself and then we'll reconvene. All right. So what I'll do is I'll do my best at interpreting this electrocardiogram, and then we'll hear from Khashayar what their interpretation was. And maybe even before I do this, because is this a good stop point, Khashayar, for me to start talking? Okay. Maybe what I'll do is before we even go into this EKG, I want to summarize the case before us, because anytime you go into any study, you have to have a pretest for a specific finding. And we have a 72-year-old woman, history of cabbage 10 years prior, with multiple coronary artery disease risk factors, including diabetes, hypertension, CKD, who only takes aspirin and insulin, but no other medication, and presented to Khashayar's hospital with retrosternal chest pain radiating to the back, to the left arm, who initially had a stone cold normal electrocardiogram, but on hospital day 2 is noted to have signs of volume overload with an S3 taking us straight to the heart for heart failure, signs of inflammation with the fever. So inflammation, new volume overload to our knowledge. We don't know how long it's existed for. And this is all in the background of her son passing away just 2 days ago. And interestingly enough, she experienced these symptoms before, but not as intense. And so on hospital day 2, she becomes hypoxemic, but is very responsive to supplemental oxygen and is found to have this electrocardiogram. And we will talk about this EKG, but first for the inflammation, and I'll be very brief here, but when someone's inflamed and they have markers of volume overload, all of a sudden I think about inflammation within the thoracic cavity and specifically inflammation of the heart. And I break that down into the myocardium, the endocardium, and the pericardium. So it's going to be very important for me to listen to the heart to see beyond the S3 if there's a murmur, which may suggest endocarditis. The troponin level is going to be very helpful because if it's elevated, all of a sudden, I'm going to be thinking about myocarditis early on. And then, of course, with pericarditis, I'll look at the chest X-ray and we'll get the echocardiogram to see if there's any evidence of pericardial pathology. All that being said, you can have a PE that causes inflammation in right-sided volume overload, not left-sided, but right-sided. And so I still think it's important to get cross-sectional imaging to evaluate those pulmonary vessels, to evaluate the aortic arch, and to just see what's in the parenchyma that might be driving the patient's inflammation. But the first test we have is this EKG, which is definitely just like looking at it, it's not normal. And right away, when I evaluate an electrocardiogram, I ask myself 3 questions. Is the QRS complex narrow or wide? Is it fast or slow? Is it regular or irregular? Just eyeballing this, it doesn't look too wide, maybe a little bit. It doesn't look, it looks irregular, and I'm seeing some waves that may represent flutter waves. Additionally, it's not fast and it's not slow. So even if this is flutter, it's going within a block that has slowed it down. But more importantly, I think looking at the ST segments is going to be vital. And you already know, Khashayar told us in that first EKG, there was no ST segment abnormalities. And when I look for the ST segments, I arrange the leads based on the coronary artery distribution, inferior, lateral, anterior. If you look at the inferior leads, and really you need to make the isoelectric line. And what I use for my isoelectric line is the preceding PR interval. You could use the TP interval as well. And it looks like there's, if you count the QRSs in lead 3, look at that fourth QRS. I don't know if that's just the machine and it's like cutting off, but that ST segment is an example of what looks really elevated. But when I look at leads 2, and then you come down to AVF, which is not, it's all the way at the bottom because it's 2, 3 on AVF. Yeah, it's not like consistently. There's some ST segment abnormalities there for sure. Then I'm going to look at one AVL, V5, and V6 for my lateral leads to just see. And what I'm seeing here is what seems to be T wave inversions. And so, Khashayar, I think my summary, and I'm excited to hear from you, is that this is definitely an abnormal EKG. There seems to be what I would describe as sort of non-specific T wave changes and maybe even ST segment changes. And the rhythm doesn't look completely regular. And there's, at least in those, in the leads of 3, 2, etc., I'm seeing multiple waves, making me wonder if there could be an irregularity there like flutter. But please teach us. I'm no expert at the EKG.
Your summary was actually great. The most important finding here is the atrial flutter. And I used the first changing EKG we got from her because we were doing serial EKGs to look for any changes because sometimes they manifest later or sooner. And this is the first one that showed an abnormality, but the next ones kept showing the flutter. So the most important part of this for us was the flutter. And this is the official read of the EKG. And now I'm gonna go forward to the fourth aliquot and give you guys some basic labs. Her glucose was 180. Her sodium on entrance was 133 on admission. Later, it got higher to 142. Her potassium, 4.4, stayed the same range. Her creatinine was 1.65, again, same range. We don't know her baseline. Her serum urea was 105 milligram per deciliters, with normal range being 17 to 43. Her CBC showed a hemoglobin of 13.1, HCT 41.2, white BC of 3.47, which got higher to 5.0 on second day of hospitalization with 85% neutrophils, MCV of 88.8, platelets of 113. Her high sensitivity troponin was 0.009, which increased to 0.027 an hour after her presentation, both of which counted as negative, but we saw a minimal raise there. She tested positive PCR for COVID-19, and her chest X-ray showed only an elevated right hem.
Oh, it seems like Khashayar may have paused. Might be internet connection. Let's see if he comes back. He has us all on the edge of our seats for sure. And he's doing such a phenomenal job of presenting this case.
I'm sorry, I think my connection got cut off.
Oh, no
Can
problem. Welcome back.
thank you. As I was saying, her chest X-ray only showed an elevated right diaphragm. Her chest sonography showed normal breathing movement and no sign of paradoxical movement of diaphragm and no sign of abnormality in the aorta. No abnormality was seen on her CT, on her chest CT. Her UA was negative culture with a normal hair.
We may have lost him again, but I'm sure he'll be back momentarily.
And yeah, her urinalysis was normal, and that's the fourth aliquot. I'm gonna put the data in chat as well because it got caught off so many times.
Thank you so much, Kashayar. Appreciate you. You're doing such a great job of presenting this, and it's really helpful that you gave us the reference ranges for the BUN. And that CT, it was with contrast, just to confirm? I assume that CT was with contrast, but if it wasn't, just let me know. And I will start interpreting the data. And if I can have just one more data point, Khashayar, what was her temperature? You said she became febrile, I think, on day 2. Do you remember what her temperature was?
Unfortunately, no,
No,
I
it's okay.
didn't.
No, no, no worries at all. This is really, really interesting. And I think we came into this case with chest pain and we right away considered the 3 life-threatening causes. And that CT scan is so helpful at ruling out a dissection and at ruling out a pulmonary embolus, a major dissection or major PE. And I think the objective data that we need to explain here is what caused her to have this hypoxemia, what's causing her to have inflammation, and then what's causing her to be in new atrial flutter. Interestingly enough, if we just start with the arrhythmia, atrial fibrillation and atrial flutter sometimes are just a way that the body is trying to compensate for a disturbance, meaning that the body is stressed because of an infection or some kind of stressor, and it increases its sympathetic drive and increases its heart rate by any means possible, even if it's an irregular rhythm. But other times, it's because there's underlying pathology like too much stimulant, like thyrotoxicosis. In fact, in this patient, I would send a TSH just to round up the workup. Significant anemia, inflammation, these are all secondary causes of higher sympathetic tone and abnormal heart rhythm. In aliquot 1, Kashayar mentioned dysuria, but I totally ignored it. And I ignored it because we're dealing with chest pain, and there's no way for me to take a urinary tract infection and explain chest pain or hypoxemia. So that's why I think my mind just put it aside. The COVID-19, the truth is there are many patients that we may swab that are asymptomatic and will test positive. Like there's a lot of people carrying this SARS-CoV-2 virus. And in a patient who has no CT findings of parenchymal abnormality, there's no doubt I would say she has COVID-19, but I'm not sure I would blame her symptoms yet on COVID-19. I'm still concerned enough that I would be investigating ulterior etiologies, but also trying to connect it that if she had COVID, could this be like a post-COVID syndrome that she's now manifesting with? The troponin is actually quite reassuring. I know it went up a little bit, but this is like the high sensitivity test, and it still hasn't made the threshold of it being abnormal. You could get one more high sensitive troponin just to make sure it's not continuing to uptrend now that we have two data points. But right now, I'm like quite reassured with the CT scan. The EKG ruled out a STEMI. The troponin is not suggestive of ACS yet. And the CT scan pretty much ruled out a significant dissection, assuming it was with contrast, and a significant pulmonary embolus. And so the question is, where do we go from here? Remember, she also has this hypoxemia that was quite significant, O2 sat of 70%. And when you're dealing with hypoxemia, once you correctly say this is true hypoxemia, I think you either say, is it radiographic positive or radiographic negative? Radiographic positive would be any cause of alveolar filling or of lung collapse. And this is radiographic negative. And when you have radiographic negative, it really comes down to, is there something that's shunting? Which this is not a shunt, because if it improved this much with just 4 liters, you've ruled out a shunt. Or is this something at the vessel? So sometimes you get a study and it may be falsely negative because the timing of contrast or because the study wasn't protocolized to evaluate for that specific finding. But I think here we have to make sure we talk to the radiologist and say, hey, is there any evidence of pulmonary embolism? The other thing that's abnormal is her thrombocytopenia. Like a platelet count of 114 is not normal. It's like going towards towards the direction of thrombocytopenia. And there, in the setting of inflammation and fever, really you prioritize sort of a DIC-like picture. So that would prompt me to send a D-dimer in this patient. And the next test that I would want, because remember, we have an irregular rhythm, we have an S3, we have lower extremity edema, we have hypoxemia, is an echocardiogram and a pro-BNP. I think the echo would be really helpful, but I really don't know yet. I'll be honest, I don't know what's going on. I don't. I'm still trying to understand the problem. I know enough that there's chest pain, there's been a stressful event. I've ruled out dissection. I think I've ruled out PE. There is no STEMI. The tropes are just mildly elevated. And the next step would be an echo to just see what the heart is doing because I have volume overload. And I also have hypoxemia that I haven't fully explained yet because the CT scan was negative. The chest x-ray could be negative and I wouldn't believe it, but the CT scan I believe for evaluating the lung parenchyma. So Khashar, where I am is still a big question mark, but my next step would be an echocardiogram.
Exactly where we were, and I'm gonna give you the echo results now. Her ejection fraction was 40%. There was no signs of left ventricular hypertrophy. Her base, we saw an base mid-inferior wall akinesis, mild diastolic dysfunction, abnormal septal motion, mild left atrial enlargement, mild RV systolic dysfunction, no valvular abnormality, and an SPAP of 35 millimeters, and no precardial effusions. And I'm going to stop there before giving you the final diagnosis. I think you're on mute.
Maybe it's best I stay on mute, Khashayar. The echocardiogram is really, really helpful because we now have an abnormal finding, and an EF of 40% is not normal. Like a normal EF is above 50%, 55%. This is more mid-range ejection fraction, which is like 40 to 50%, but it's a low EF. And you have apical, is it inferolateral wall motion abnormalities with apical sparing? Is that correct, Khashayar, for the echo? Or you have regional wall motion abnormalities, which now the question becomes, I think the problem we're solving is like one of volume overload, and it's due to the heart. That's the problem we're solving. But we have to incorporate the inflammation. And so she does have COVID-19, and COVID-19 can certainly cause inflammation. COVID-19, I bet if you Google it, can cause myocarditis. And the question is, how do we make more progress from here? The most common cause of reduced EF in 2/3 of comers is coronary artery disease. This patient has every risk factor for it, and she had a CABG a decade prior. So already what I'm thinking is I'm going to probably need a coronary angiogram, and those diagnoses that can mimic stress-induced cardiomyopathy and myocarditis. But this patient doesn't actually have SC segment elevations, but we really need to rule out, new onset coronary disease. So a coronary angiogram is one option. A coronary CTA is another option. The coronary CTA, even if you find abnormality, you might not be able to accurately estimate the functional flow reserve, which is what cardiologists use to put a stent. Though a few years ago in Cleveland Clinic, their coronary CTAs actually can calculate the FFR, the functional flow reserve. But the other tests that can, so right now I'm just discussing the possible tests that I would do next. The other test that we can do is a cardiac MRI with gadolinium, because if you are worried about myocarditis, you will see delayed gadolinium enhancement because of this inflammation, but it won't be in a coronary distribution. It will just be patchy. And myocarditis is a diagnosis that, oh my gosh, it's like a scary one, and people can crash and burn. The other thing is you want to review the echo with the cardiologist to see if it's consistent with Takotsubo's. Like, could you have COVID-19 pneumonia causing fever and then new onset Takotsubo's cardiomyopathy because of her son passing 2 days ago? There's specific wall motions and sparings that take place in Takotsubo's I always have to remind myself of, but she definitely had a stressful event. The one thing that I haven't explained yet is her hypoxemia. I'm still a little perplexed by that, and I would try to wean her off the oxygen. I don't want to invest too much time in it. Maybe it was just she was sleeping and was hypoxemic and then was put on oxygen, and all of a sudden she improved and has like sleep apnea, for example. So if I were to summarize this case, I would say that we have a patient who has new onset volume overload because of the lower extremity edema, the S3, and we have an echo finding that's abnormal. So new volume overload due to the heart. And within the heart, the problem I'm solving is wall motion abnormalities and a low EF. The thing I have to make sure it's not is coronary artery disease. I don't think it's ACS because, boy, the troponin really didn't go up. But remember, you can have ACS without trope or EKG changes known as unstable angina, but she didn't really give us that story of unstable angina. And then I'm worried about like myocarditis and stress-induced cardiomyopathy. I would have to just review the echo findings and like where the wall motion abnormalities are. But my next test would either the coronary artery disease shouldn't cause a fever. So a good way to link everything might be myocarditis, but she did have that stressful event. So I'm thinking, am I going to get an MRI with gadolinium, cardiac MRI with gadolinium, or am I going to go and pursue a coronary angiogram? I'm going to make this final point. My threshold to do a coronary ischemia evaluation in her is so low. Look at the patient she is, history of CABG, and all these risk factors. But I would love to learn from you, Khashayar, as to what your team was thinking and what you guys did next.
Thank you so much for the great discussion. And we were moving along the same thoughts, and there were so many things in the air just hanging. Like we have this diagnosis, we have that, we have this symptom, we have that. There's so many things happening. It's day 2 in the CCU, and the patient is here. She looks well, but you can't trust that. And our primary concern based on her history was still an ACS, and our attending was like, I want to look at the vessels. And so she sent her to another center with a cath lab for an angiography. And unfortunately, I wasn't able to follow the patient there for an complete final diagnosis, which is why I named the case Another Break in the Wall. We have only the breaks, we don't have the complete wall. But yeah, the patient was sent to another sentence with a presumed diagnosis of heart failure complicated by COVID-19 and atrial fibrillation.
I love this case so much. Why do I love this case so much? Because this is the fundamentals. This is the bread and butter medicine. This is the stuff that we see day in and day out. And Kashmir, I'll summarize my main takeaways and then give you the mic to summarize your main takeaway. Actually, you know what? I've spoken so much. Why don't you just summarize your takeaways from, like, what did you learn and what do you want the audience to leave with based on your experience with this case?
Something that was a great learning experience for me was something that we actually practice a lot in VMRs, and that's framing. What do you take as your main viewpoint? For example, one thing we were really confused with was the dyspnea. It could be caused by the infection, but it doesn't show up on the CT. It could be caused by the heart failure, but it doesn't fit well. It has so many causes, and based on where you start looking at the patient, the decisions you make for the patient changes. And the most important lens here was management. This patient is in a high risk situation. You can't be burdened by the diagnostics. You have to move fast, fast, fast. This was a very fast paced case for me. Like, I gathered all of this happened in 2 days. And that was really interesting for me.
I love that so much. And I think that's why everyone is here right now, is to get better, get another rep. Because these cases do come by really, really fast. And you, by presenting it, is another opportunity to reflect and to grow. So you're better for that next patient you see that comes to your hospital. Thank you so much for this, fundamental case. So, so important. I think we talked and did a lot of good stuff. Gerardo, I want to give you the mic to take it home for us and teach us. You're in such a beautiful office. I feel like you're the president, and we got to listen to whatever you say, my friend.
Yeah. Hello everyone. So now to finish the case, I will read the teaching point for today. And well, we first had a patient with the problem of chest pain, and as Reza said, the key to discover the diagnosis is to evaluate the tempo and the quality of the pain. And there are many causes of chest pain, but there are certainly some not to miss causes of chest pain that we have to consider first. And those, Reza mentioned three of them, which is acute coronary syndrome, aortic dissection, and pulmonary embolism. But of course, in the setting of this patient, the analysis had to be more specific due to um, the the situation that the patient was going through, which was a very stressful episode in her life, which could indicate or could point us towards another cause of chest pain, with this type of history, which is stress-induced cardiomyopathy or Takotsubo's cardiomyopathy, right? Which is one of the DEX that we have to consider in the cardiac part. And now, as we received the findings in the many tests that had been done to the patient, we certainly wanted to exclude the most morbid possibilities, differential diagnosis. So CTA comes into play, and it's and it is a very useful tool for assessing different emergent causes of chest pain that we were considering in this patient that had many risk factors for these conditions, which are aortic dissection and pulmonary embolism. And later we found that the patient also had some problems in the cardio in the heart electrical system, and we found AFib. We found A flutter, sorry, and AFib and A flutter can be due to, or can be interpreted as a response of the body due to an upregulation of the sympathetic nervous system, and it can be understood as a compensatory mechanism due to a disturbance that we were seeing in the patient. So, in our analysis, it was important for to establish the causes of the different phenomena, the phenomenon that were happening in the patient, and one of them was the hypoxemia. And Reza mentioned a very useful a very useful concept to try to explain the hypoxemia, which is we first have to see if this is a true hypoxemia or a false hypoxemia, and we can also look if there are some radiographic signs that can point us towards a direction, or there are not. And in this case, this was a case of radiographic negative hypoxemia, and we can establish or try to think about the causes in trying to think about a possibility of a shunt or problems in the vessels, right? Because we know that problems like pulmonary embolism tend to be image negative as well. And well, then we looked at the echocardiogram, and we have to analyze this echocardiogram in the setting of an image negative chest pain, right? And we first thought that the possibility of ACS was far away, but then at the end of the case, we found that we kept it in our differential diagnosis, and we found in the echocardiogram some findings that could suggest coronary artery disease, because we found that there is a low left ventricular ejection fraction, which the most common cause is this disease. But we also had to analyze the case based on the other findings, which dictate the systemic inflammation and the findings of the low left ventricle ejection fraction. And this could be explained, for example, for myocarditis, and this patient had a COVID-19 positive test, and we know that COVID-19 has many systemic causes many systemic problems, and one of them could be problems in the electrical conduction system in the heart, producing these findings, and also producing a myocarditis due to COVID-19. And then since we didn't find a specific answer or a specific diagnosis, further studies were conducted, and were suggested to perform a cardiac MRI with gadolinium and cardiac angiography, just because the possibility of ischemia or inflammation due to myocarditis or ACS was still into play. But then we established that the final diagnosis was heart failure, that could be due to or was associated with COVID and atrial fibrillation and flutter. So those are the main teaching points that I did. And thank you so much for the case and for all the learning that we had today.
Gerardo, that was superb, my friend. Thank you so much. Phenomenal job of organizing the teaching points and reiterating the most important ones. Sometimes I feel blessed because You guys make us sound smarter than we actually are. So thank you for doing that, my friend. Kashayar, sign us out. You presented the case today. Sign us out with a beautiful message. Give us good energy.
Thank you so much for this environment where we can practice all of this. Like every VMR I show up to, I learn more and more and more, even if it's a case that I've seen before. There are so many new lenses. Thank you so much, everyone. Have a good rest of your day. Goodbye.